1, 2, 3.
Bismillahirrahmanirrahim. Assalamu alaikum everybody. So welcome to the day 4 of the COVINAR 2. And today is the day 4 as well as the last day of the COVINAR. Today we have 3 presentations. Thank you so much for your attendance. We have been seeing more than 300 participants almost in each session. And thank you so much for filling out the evaluation forms as well as the pre-test and the post-test. So today we have 3 presentations. The first presentation will be introduced by Dr. Natasha.
Thank you, Dr. Tariq. We're so pleased to have all of you with us today. Our first presenter of the day is Dr. Asad Latif. Dr. Asad is the chair of the Department of Anesthesiology at APU. He's an alumnus of batch of 2001 and he has done his residency and fellowship from US. His areas of clinical expertise include anesthesiology, critical care medicine, and transplant surgery. Dr. Asad is leading a recent project at APU which is looking to improve national capacity to care for critically ill patients with COVID-19. And this is through a multifaceted approach involving infrastructure assessment, triaging, and teleconsultation. Today, Dr. Asad will talk on respiratory support in COVID-19 patients.
Thank you, Dr. Natasha. And assalamu alaikum everybody. Thank you for taking the time. We're going to be talking a little bit about respiratory support in COVID patients because COVID-19 has more serious complications have been related to respiratory care. As a starter, I do not have any relevant disclosures for this talk. And in this talk, we're going to go over a few things, a little bit of base, but then hopefully get and working on the more of the clinical aspects of care. So we'll review the respiratory failure specifically in COVID, understand the types of respiratory support that are commonly needed, and talk about some special considerations and some experiential learning we've had regarding respiratory and ventilatory support in these patients. Now, here's a slide that I believe some of you might have seen in the past, and it's a little bit of a rehash of an earlier talk that Dr. Masuma has probably done regarding pulmonary physiology. But basically, in COVID, we are seeing a 3-stage sort of thing. First is early infection with the viral response, which has minimal to no clinical symptoms. At the worst, a mild flu. This is where the vast majority of patients end up lying. It's the patients who reach stage 2 or stage 3 of a response that start having more of a host inflammatory response, and this is can lead to respiratory symptoms, shortness of breath, hypoxia, all the way to severe hypoxic respiratory failure, an ARDS, shock, cardiac failure, and the secondary complications of COVID that we're seeing and can often be fatal. But my talk is more of a clinical variety, so we're going to focus more on the clinical manifestations and classifications of COVID-19. This has changed a little bit from earlier days. When we started out, it was 3 categories. Now it's become 4 with 5. Asymptomatic, mild, moderate, severe, and critical. The vast majority of people, more than 85%, fall in the asymptomatic to moderate categories. And these are the people who don't require much in the way of support. We are more concerned in terms of respiratory support being needed for moderate, severe, and the critical clinical category of COVID-19. And this is where hypoxia starts manifesting, especially on room air. Now, hypoxia is a general manifestation, but it can be complicated or worsened by a couple of things. The first is pneumonia, which can be, and we'll talk about what the definition of pneumonia is, can occur along with the COVID viral infection. And secondary is cytokine release syndrome, which is defined as a acute out of proportion immune response to the COVID-19 vaccine clinically and by chemical parameters is defined in the presence of moderate, severe, critical disease as an elevated ferritin which lasts more than 24 hours, and there are certain markers, more than 1,000 micrograms per liter at least. Leukopenia can happen, and any two of the following, with the ferritin being high, LDH being elevated, D-dimers being elevated, more than 1,000, CRP being elevated more than 70. And if any 3 are present on admission, At the same time, then by itself, even without a documentation of a rise, you can meet the parameters for CRS. And I know these are details that were shared with you earlier as well. And these are the patients that fall in the severe to critical categories and in whom the hypoxia is severe enough to cause respiratory distress. Pneumonia is something that can happen because of COVID and secondary to COVID as well. Over here, pneumonia is generally in a stable patient with respiratory or symptomatic symptoms or signs. And stable pneumonia or mild pneumonia, where we're starting off, is the ability to maintain oxygen saturations over 92% or over 80-90% for patients with chronic lung disease with supplemental oxygen. For these sort of things, you're going to see things like increased worker breathing, some clinical radiologic signs of lung involvement, but the lab parameters might not be severely impaired. Severe pneumonia is when you have basic pneumonia with fever or suspected respiratory infection, plus things that are suspicious of high levels of worker breathing or strain on the body, physiologic stress such as high respiratory rate, more than 30 breaths per minute, severe respiratory distress, extremely clinical, or an inability to maintain their oxygen saturations despite low levels of supplemental oxygen. This progresses in COVID to acute respiratory distress syndrome, and this is a specific type of hypoxic respiratory failure which is due to pathophysiologic changes within the lung itself, and most frequently due to an overwhelming immune response to the inciting factor, which can be the primary infection itself, or a secondary immune response, or a secondary infection that might occur. Onset generally within a week of a known clinical insult, which in this case, in the case of COVID patients, is the COVID infection itself. It's supported by chest imaging, where you see things like bilateral opacities, not fully expanded by volume overload, not fully explained by volume overload or other secondary issues. Origins of these pulmonary infiltrates are not completely clear, because it's not necessarily cardiac failure, not fluid overload, and other things need to be excluded. Oxygenation impairment is one of the defining characteristics, where in ARDS it's categorized, we're looking at the PO2, P to F ratio, the partial pressure of oxygen versus the fraction inspired oxygen. When you divide the two, a ratio of less than 300 is considered impaired. 200, 300 is considered mild, 100, 200 is considered moderate, and less than 100 is considered severe. And this is with increased PEEP requirements. Now, when the PO2 is unavailable, we can look at a different fraction between the pulse oximeter and the fraction inspired oxygen, which, if it's less than 315, suggests ARDS, including non-ventilated patients. Now, this was traditional ARDS, and what we're seeing in COVID is a little bit different. Differences in COVID for ARDS is primarily along the clinical parameters. What we're seeing is more significant heterogeneity in terms of, and we'll get into the numbers for this, in terms of the pressures and the compliance of the lung. And what we're starting to see is that it might actually be worsening over time. In terms of radiologic findings, for COVID, 2/3 of patients present with extra abnormalities, and remember, people who present are the ones who are symptomatic to an extent that they have to present, usually because of hypoxia. Of these, CT findings seem to be occurring even before lung findings, and the vast majority, more than 86% of patients, present with CT abnormalities at the time of presentation, even if it's with mild symptoms. The most common CT findings are ground glass opacities or bilateral patchy infiltrates in more than half of patients. Now, these are two different CT findings. On the left is more of a spectrum of CT findings that you will find in general ARDS. What you're seeing on the leftmost are ground glass opacities. Then you start seeing local consolidation and bilateral consolidation. And general ARDS is usually a combination of ground glass opacities and consolidation, particularly towards the bases. What we're finding in COVID is a slightly different radiologic series, especially in the early stages. In simple COVID ARDS, we're seeing primarily ground glass opacities without the significant component of localized consolidation or bilateral consolidation that occurs in general ARDS. And this leads to certain differences. So, why are we concerned about COVID-19 and respiratory support in these patients? That's because, at least in the data that we've seen in the published literature that has come out significantly over the last year or so, a significant proportion of patients, more than 3/4 to more than 85%, 75 to 85% of them, who are in the ICU end up requiring to be ventilated. And this is a very high proportion. This is not something that we're necessarily seeing in a place like Pakistan. Pakistan mein jo hum dekh rahe hain, is that the use of ventilation for COVID is less than that reported in the literature. There's many reasons for this. And these need to be explored a little bit further. Some of these are probably related to our approach towards critical care and our approach towards ventilation. For example, during our work with some of the ministries and with the public sector in COVID patients, we went to multiple units across the country that were set up de novo by the ministries. And in one place had taken care of almost 92 patients with COVID over a period of a month in July when things were the worst, of which 36 expired, and this was the whole spectrum of COVID. These 36 were made into their ICU, but only 6 of them went on the ventilator. And this was a stark difference from how things might be in the West, where pretty much everybody who progresses to a severe enough COVID to expire or towards mortality ends up being on a ventilator before that happens. On inquiry, on casual inquiry, it was obvious that there was a couple of things that hindered this conversion of critically ill patients to becoming ventilated, which ranged from provider inexperience or uncomfortableness with intubation, as well as patient discomfort with intubation and multiple patients actually saying that no, we refuse to be intubated with a ventilator because that is a fate worse than death. So these perception issues have probably decreased the proportion of ventilated patients in a place like Pakistan and many other low middle income countries. Building on the differences of COVID to ARDS, some of the initial literature suggested 2 or 3 main differences, as I highlighted earlier, which is that the compliance in COVID ARDS for COVID patients, severe COVID patients, is probably better than regular ARDS. And their PEEP requirement is less, and their oxygenation is worse. Their P to F ratio is worse. However, some recent studies have shown a slightly different story, and this was published this recently in the Blue Journal, and this involved a cohort of patients in Boston, in Mass General and Beth Israel. And what they showed is they showed respiratory mechanics and indices over time in COVID patients. And initially, on the first day, it was exactly as was previously described in cross-sectional studies, primarily out of Italy, which showed that COVID ARDS patients or intubated patients with COVID because of ARDS had lower PE to F ratios, worse hypoxia, required less PEEP, and had better compliance. However, in this study, we're learning that over time, these indices are getting worse and becoming more like we would expect with poor P to F ratios. That means more significant hypoxia, higher PEEP requirements, and poor compliance. And this is also what, in our experience, we're seeing at a place like Aga Khan over the last month or two, where patients presenting to the COVID, with COVID, critically ill or critical manifestations and are being admitted to the ICU are presenting at a later point in their disease progression. Earlier it was between 5 to 7 days. Now it's closer to 10 to 14 days after initial COVID positivity. And we're also seeing that these patients are requiring to be ventilated for longer periods, have worse compliance, and are acting more like traditional ARDS with prolonged poor P to F ratios, prolonged hypoxia, higher PEEP requirements, and worse compliance that just isn't getting better. And there's many reasons for this that we can hypothesize. Some of these might be because of our changes in the viral epidemiology, changes in the patient population that is now getting COVID, and also the changes in our treatment modalities. So we're going to shift gears a little bit to talk about hypoxia and the type of respiratory failure itself in COVID. A basic definition to start off: respiratory insufficiency versus respiratory failure being two different things. And respiratory failure, insufficiency is when we're struggling to meet metabolic demands of the body, things like hypoxia, oxygen requirements, as well as clearance, which are two basic functions of respirations, providing oxygen to the body and clearing the carbon dioxide. And failure is when you can no longer meet them. Correspondingly, we have three types of respiratory failure: hypoxic, type 1, hypercarbic, and mixed. And in COVID, what we're seeing is primarily a hypoxic respiratory failure, and in patients who might be presenting much later or with critical disease progression and have progressed to RDS, might be a mixed type of respiratory failure. It is very rare for somebody with COVID to present with hypercapnic respiratory failure. Hypoxic is a primary type. And the management of respiratory failure in most patients and in COVID overall is supportive. We do not have a primary cure for COVID. Our management, especially in critical care, is primarily supportive and centers on oxygen therapy. Starting off with the less severe patients, the goal is ultimately to avoid hypoxemia in patients receiving supplemental oxygenation and target saturation of oxygen over 88%. As long as you can see the pulse ox on a continuous sort of monitor. Otherwise, if you can't see it, then you would want to have a higher SpO2 goal if you're only checking intermittently. And based on that, you will be providing oxygen, and we'll talk about the various ways you can provide oxygen to these patients. Like I said, that most patients with COVID have silent hypoxemia, and the main clinical finding that we might be seeing when they present is increased minute ventilation. What does that mean? They're actually breathing much faster than normal. Most people at baseline have a minute ventilation requirement of about 6 to 8 liters. In COVID, we're seeing a minute ventilation requirement closer to 14 to 16 liters per minute. And while this doesn't seem like much, if you breathe normally at a rate of about 10 to 14, these people are showing up with respiratory rates in the 20s to 30s. And as things progress, it gets worse and worse. The management is supportive, as I mentioned earlier. And one caveat we need to be careful of with all type of respiratory support is we need to ensure the safety of healthcare staff with all patients needing respiratory support by maintaining a strict adherence to proper PPE. So, delivery of supplemental oxygen can be various ways, and this starts with moderate intensity COVID, right? From nasal prongs. On the left, regular face masks, Venturi face masks, and these are regular face masks with these small adjustments and things which allow for setting of the FiO2. And on the right is a non-rebreather face mask. These are 4 very different devices with 4 very different purposes. The non-rebreather is noted for the oxygen reservoir bag that it has. Another modality for respiratory support is a high-flow nasal cannula, and this is something that has been increasingly used and flaunted in COVID. And this is not the regular nasal cannula. This is a special device, which I'll show you in just a second, where along with providing oxygen, we're able to provide humidification and compressed air at a high flow. So we can generate kind of a PEEP effect, especially during expiration when we're breathing up against this high flow. Flow rates can be up to 60 liters per minute in adults, and the machine can actually go higher if needed. And you can provide an oxygen air blend where you can provide 21% to 100% FiO2. And humidified oxygen should be considered at all times because of these high flow rates. You have a significant amount of desiccation and dryness of the nose, which can lead to trouble. The high flow nasal cannula actually looks like this. This is a different type of nasal cannula. It is much thicker and has prongs that go into the nose. It has a involved contraption where you have the sterile water supply to humidify it, air oxygen blender with a flow meter that goes significantly higher than regular flow meters. Remember, the regular flow meters in the wall go to 15 liters. These go up to 60 to 80 liters per minute. And then you have a heated breathing circuit. So it's heated, humidified, high flow oxygen that's provided. And often it has a base unit where you can change these settings. When we think about these things, what we were talking about before was supplemental oxygen. Now we're getting assisted ventilation, in which high flow nasal cannula should be considered assisted ventilation. You can see that on the left. In the middle, you're seeing BiPAP, CPAP masks, external non-invasive ventilation. And on the rightmost, you're seeing intubation for patients that are on ventilators. These are three different types, and I would consider this an increasing progression of respiratory support. One very important thing, so with all these types of respiratory support, the goal is to maintain your SpO2. And that is the basic goal of respiratory support. Maintain your SpO2 over 88, where PO2 over 60. Now, I've kind of listed these things in an increasing order of how much oxygen they can provide and how much they can support it. And it's important to note that setting flows very high doesn't necessarily provide an incremental benefit, especially with the supplemental oxygen modalities. So things like a nasal cannula or nasal prong, I've seen them set at rates of 10 or 15 liters. There's really no benefit of these things. So here's a table to help you think about these things, because the most effectiveness is up to a liter, 6 liters per minute. The issue with these supplemental oxygen modalities is the lack of a seal. तो अगर आप नाक के अंदर nasal cannula डालते हैं और आप उसको 20 लीटर पे भी कर दें regular nasal cannula को, you're going to entrain room air around that, क्योंकि cannula छोटा होता है और आपके nostrils बड़े होते हैं. You can drain air through around the cannula, from your mouth, whatever, and that limits what your maximum FiO2 is. So the nasal prong, going over a rate of 6 liters per minute, it will not give you additional benefit in terms of FiO2, and the maximum FiO2 that can be achieved with the nasal prong is about 45%. So, if your oxygen saturation is still below 88 with 45% nasal cannula at 6 liters, then it's time to move on to something else, which provides a higher FiO2 fraction-inspired oxygen. The next step is a simple face mask, and those are most effective from about 4 to 10 liters. And at 10 liters, it maximizes how much FiO2 can provide, and it's generally between 55 to 60%. Putting a simple face mask at 15 liters won't increase the FiO2 beyond 60%. Similarly, with Venturi face mask, which is the same type of face mask as you saw here, just with an additional piece, that orange piece or different color pieces. The main benefit of the Venturi face mask or simple face mask is not the increased FiO2, because you cannot, like I said, provide more than 60% with the face mask just because of the mask itself. It's the fact that flow becomes fixed, and it helps you dial exactly what the FiO2 is and figure out the mixture of air to oxygen. So again, with the Venturi face mask, even if the plastic thing says it gives you 100%, the actual delivered FiO2 to the patient is not more than 60%, because you're able to get air from around the mask itself. The seal is not perfect. A non-rebreather face mask, the one with the bag, is better, and over there you can achieve FiO2s of close to 95% because of the bag itself. With the bag, what happens is when you take a breath in, instead of from air outside, because that has you have this reservoir of oxygen which is still 100%, and you breathe that in because that is low resistance. You preferentially breathe that compared to air outside. So that's why with a non-breather face mask you can provide an increased FiO2. Now with all three of these modalities, you can't actually change the pressure with which oxygen is provided, just the percentage of oxygen provided. To provide oxygen, high amounts of oxygen with pressure also, that's where we get to assisted ventilation modalities, high flow nasal cannulas, CPAPs or BiPAPs, non-invasive ventilation, and then invasive ventilation. And this is where the high flow nasal cannula is beneficial, because it can provide some additional pressure in the form of PEEP, and that can achieve FiO2s with its design up to 95%. The flow is fixed. CPAP, again, can take multiple flow rates. It's normally go to 10 to 15, can go up as high as 25%. But it's important to note that the flow rate doesn't correspond with the FiO2. That needs to be calculated beyond the flow rate itself. And the FiO2 provided depends on the seal that's achieved with the CPAP. CPAP or BiPAP mask with a poor seal is really not much better than a simple face mask because you can entrain air. Its true benefit really comes when you can't get air from the outside. So pay attention to the seal. Now, just some general caveats about the assisted ventilation types that we have provided. We can provide with high flow nasal cannula. Again, you want to use the lowest flow necessary to maintain an oxygen saturation more than 90%, and this is true for all the modalities of respiratory support that I've discussed. You want to use the lowest possible modality in that order that can maintain oxygen saturation of more than 90 to more than 88%. This has the highest potential for aerosolization, one thing to remember, so you need to ensure healthcare worker protection when it's being used, and try not to use it in shared spaces. So if you're using it for a patient, the other patients, there either should be no other patients in that room or other patients in that room should be known COVID positive, not suspected, or not COVID free. And you should ideally not use it during transport because then you'll be aerosolizing all around. Similarly with CPAP and BiPAP, non-invasive ventilation, it's very important that when you start it, use serial assessments on a regular basis to see the clinical trajectory. This should be about every 2 hours. And with these serial assessments, you should be looking at two things: the worker breathing, how fast the patient is breathing, what are the tidal volumes, are they increasing or decreasing, how are the hemodynamics, and their oxygenation. Ideally, through arterial blood gases, looking at their PaO2 to see if that is being maintained or decreasing. And then also with CO2 clearance, whether their PCO2 is getting worse or better or staying stable. Technically, if you're not improving in these three parameters, worker breathing, oxygenation, and CO2 clearance, you're probably getting worse. And there are studies, so the recommendations are, if you're not improving over a period of 2 hours or a day at the most with continuous non-invasive support, you should transition to the next step, which is invasive ventilation. Studies in which this has been delayed more than 2 hours have been associated with higher mortality in patients who do not transition from non-invasive ventilation to invasive ventilation in a timely enough fashion. And in the final section of caveats for mechanical ventilation for ventilators, we've spoken about how this is similar to ARDS, but slightly different, at least in the early stages, where it's primarily ground glass opacities and not consolidation, which probably allows us to use a modified low tidal volume strategy. The ARDS recommendations are for a strict 6 ml per kg of ideal body weight. This is calculated by height. In COVID, what we're seeing is probably a little bit more liberal strategy up to 8 ml per kg, and this is necessitated by their high minute ventilation requirement that we're seeing. So often we have to go a little bit higher, up to 6 ml per kg of ideal body weight to meet their respiratory demand in terms of high minute ventilation. And this is manifest in their CO2. We want to optimize PEEP and FiO2 ratios. Generally, the PEEP requirements, there are PEEP to FiO2 tables that are used for ARDS. Again, many of these COVID patients fall a little bit off that because their PEEP requirements might be less than traditional ARDS. So that if you're going to increase one, at least initially, go up on the FiO2 compared to the PEEP. Regular proning has been shown to be tremendously beneficial in intubated patients, especially those with a low P2F ratio less than 200. And this benefit isn't a one-time thing. A question that's often asked is how long do you prone for? And our experience over here has been that patients who are prone one-off, ek din ke liye, 2 din ke liye, and don't get the same benefit as patients who are prone for continuous days, 3 to 5 days. So the decision of when to stop proning, and we've had patients who've been proned subsequently on continuous days for 7 to 10 days as well. The decision to stop proning, in my opinion, should not be considered to stop for less than 3 days, at least 3 days continuously, probably 5 days. And that decision to stop proning should probably depend on patient's clinical condition. And by that I mean you're almost always going to see a benefit in the P2F ratio when you prone. When you put them supine again, that benefit goes away and their PO2 drops. When that drop in PO2 between the prone and supine positions either goes away or is minimal, is probably when you should stop proning. That generally happens around day 3 to 5. In good cases, might take longer. Another issue that often happens in mechanical ventilation is vent dysynchrony, and this is where a lot of people, including us, have had trouble. And this Normally, we think about it as in terms of sedation, but in these patients, it's probably because of high significant respiratory drive, high minute ventilation requirements. Like I said, they need about 15 liters or so. This is very difficult with 6 ml per kg, which is why we think about higher tidal volumes. But for them, the caveat still holds that we should try and increase, preferably match their ventilator requirements by increasing their tidal volume or their respiratory rate rather than over-sedate or paralyze, because that is starting to have unforeseen consequences of critical illness neuropathy, critical illness myopathy, and inability to wean off the vent because these patients were intubated, paralyzed, and sedated for extended periods of time. And we all know the benefits of minimizing sedation ventilated patients. With that, I'm going to stop and thank you all, and my apologies for going over my time.
Thank you so much, Dr. Latif, for an excellent talk with a number of clarifying questions which might be in the people wanted to ask.